with melanoma. So our next speaker is a close friend and collaborator. His name's Robert Andtbacka. He comes to us from a very small town in Finland, where he learned to play hockey, among other things. And then he moved to Canada as a very young man, I think age 15, and did most of his education there, including medical school and surgical training in Montreal at McGill. From there, Robert went to the MD Anderson Cancer Center, where he trained for another 3 years to learn how to do surgery. He was under the mentorship of Merrick Ross and Jeff Gershenwald there, two of the nation's leading experts in cancer surgery. Here, Robert has really thrived as an internationally known investigator in this field of injectable therapies, and they're very important. They are drugs that are precise, they stimulate the immune system, and they have very low side effects. And for those patients that are appropriate for them, they've turned into a terrific therapy. And I think there are some in our audience who have received TVAC and other injectables with Dr. Andtbacka. And then finally, I'd just like to share with you that he truly is one of my best friends. I just feel privileged to have Robert working in the clinic right next to me. We share a lot of moments together as very close friends and collaborators. So Robert, take it away.
Thank you very much, Ken, and I really appreciate being here. I really feel like this is sort of friends and family that I'm talking to today. So, and again, if I say names, I realize we are under HIPAA and I can't say names, but you're all here, so I think there's a consent that if I say your name, you're okay with my saying your name. So let me see if we can get the talk up here. So, let's see. Where's the mouse? Where's the mouse? Oh, this side. There we go. Thank you very much. So what I want to talk to you about today is really something that is not a new thing. We've been doing these injections for a long, long time, but I think that the way we look at them really has changed over the past few years. Now, one thing I should say also that I do have a number of disclosures to make in the sense that all of this research that you participate in, and you really are the ones that we should thank for all of this, because I see many patients in here who have participated in the research that I'll show you here, and you are really the ones that are contributing to making this a success. But all of this would also not be possible without the support from pharmaceutical companies and so on. So all of that, this is really driven by them. It's truly amazing, as Ken said, and as Sherry said, that in a short period of time, the treatment for melanoma has changed completely. And what I say in clinic, and many of you have heard this, is that if you read something and it's more than 12 weeks old, it's already getting out of date. And there's very few things in medicine that is moving as quickly as melanoma is moving right now. And this has led to that on major journals, they have said especially this immunotherapy, activating the patient's own immune system to fight the cancer, it really has been a tremendous success. And you've seen this slide already, and the reason that we show this is that for us, it's extremely exciting that we went for years, 40+ years, that we had no treatment that worked for melanoma. And then all of a sudden, by understanding how the immune system works, by understanding what the mechanisms are that makes melanomas grow, we then have developed multiple therapies in a very short period of time that have been approved. And one of these therapies is telimagene laherparepvec, also known as TVAC. Now, this is a virus. It's a herpes simplex type 1 virus. And you may ask, well, what is that? Herpes simplex type 1 virus is something that you may potentially go home with after a good night in Vegas. The other thing I should say that about 60% of you here have had a good night in Vegas, and you already have herpes. You may not know this. And it's a virus that we have used to fight cancer. And you say, well, how can we use viruses to fight cancers? Aren't viruses bad? Well, viruses can be bad. They can actually cause cancer, such as hepatitis virus for liver cancers, human papillomavirus for cervical cancer in women, but also for head and neck cancers and so on. So viruses can be bad. But at the same time, we have to realize that something that is bad may also be good. And so what we've done with this, we've been able to take these certain viruses and change them. And change them so that they really fight cancer rather than causing cancer. And one of these viruses is TVAC. And the way this works is we take the virus and we've changed this. So the virus really can only get into cancer cells and not into normal cells. And what we do is we inject this into the tumor underneath the patient's skin or in a lymph node. And once we've injected this, the virus then seeks out the tumor and gets into the tumor. Inside the tumor, it produces new virus particles, and that leads to these tumor cells bursting open. Now, melanoma specifically is really good at hiding from the immune system. And that's why I think in the past, melanoma has been able to spread in patients without the immune system really acting against the melanoma. But what happens now is that when we burst these cells open, you have cancer proteins inside the tumor that is now exposed to the immune system. And the virus then comes in. First of all, the immune system says, well, there's a virus here. I don't like the virus. We need to act against the virus. But also the same thing, the immune system says, well, on top of that, there are these proteins that we haven't seen before. These are cancer proteins. We need to act against this. So the immune system comes in, starts acting against the tumor right where we've injected this virus. But also it creates a memory in the immune system and tells the immune system, if you ever see these proteins anywhere else in the body, you need to go out there and fight them. And I think that's sort of the second effect of this sort of the immune activation and really using the patient's own immune system to fight their own cancer. So why do we do this in melanoma? Well, we do it in melanoma because melanoma, as Sherry said, can occur in the lymphatic system and it can be underneath the skin. And I know, I see many of you in the audience here who've been in similar situations and you've had these in-transit lesions. Well, what's great about that is we can actually use the virus then to inject this into these lesions that the patient has underneath the skin. So what kind of lesions do we inject this into? Well, we have these dermal lesion, which is sort of on top of the skin. We can also inject it into lesions just underneath the skin, and even lymph nodes. This is a CT scan. And I know many of you, we've looked at these scans together in the clinic, and these CT scans are lymph nodes that are big in the neck here that we can inject this into. Now, we can even inject this into lymph nodes that are deeper. We use an ultrasound for that, usually to gain access to that lymph node. But we haven't so far injected lung lesions and liver lesions. Not that we couldn't do it, but it hasn't been part of the studies. But we're opening studies right now where we're injecting this into the liver directly. Now, TVAC is not the only virus that we're using for this. We also have Coxsackie virus. We have a virus called HF10. And this is just a laundry list of all of these new agents, viruses, and other types of treatments that we're using to inject into tumors. So how well does this work? Well, for some patients, it can work very well. And I can't say names, but if you recognize these images, you know, some of you are included in here. So this is one of our patients that has a lot of melanoma on the arm here in transit lesions. And if you see, when we inject this virus often, this area becomes really angry and red. And that's because all these immune cells are now going in trying to fight the melanoma. And as we continue injecting, you can see that after a few injections, then the lesions go away. And this is another patient that we can see at the ankle here. And we can see that by the second injection, this tumor is getting really big. Before, for cancers, when we saw tumors grow, we said, well, that's bad. That means that this is not working. We now know for the immune system that that may not be the exact reason. The reason the tumors often get bigger is because of these immune cells going in trying to fight the tumor. So this may actually not be a bad thing, but may potentially be a good thing. And as we continue injecting, then you can see that the lesion goes away. The other thing we also know for many of you who are patients and you've been through this, that when the tumor gets bigger, you get more worried. And usually we tell you, don't worry about it. We see this half of the time that it gets bigger before it gets smaller. So the other thing that we also found with these viruses, often in patients that have a lot of this in-transit disease, and you can see this patient has had multiple previous surgery to try to cut away these melanoma lesions, but we can't cut away all of them. Now, we only inject a few of these, but we see responses in both the ones that we inject as well as the ones we don't inject. This is another patient that we can see that you have many lesions here on the arm. We only inject a few, but we see responses in both the ones we inject and the ones that we don't inject. So that really shows us that we're activating the immune system to go and fight these melanomas, and we're educating the immune system. We also see this sometimes in patients that have metastases to the lung. This is a patient that has lung metastases that we see that even those lung lesions get smaller, and that's usually through activation of the immune system. Now, we have many patients that actually have complete responses to these therapies. So TVAC, for instance, all the patients who took part in that study, 17% of the patients who were treated with TVAC had a complete response. So that's something that we'd like to see in patients. But also there are patients, as Sherry said, that it doesn't always work for everyone. So we still have a lot of work to do. Now, this is called a swimmer's plot. Now, in melanoma, we are extremely excited to show these things. 10 years ago when I started, no one showed these things because a swimmer's plot means that if you start from day 0 and then you look at how long the patient is responding. We never had any responses, so we couldn't show swimmer's plots. Now, when we go to meetings, everyone wants to put these things up because it shows that the longer this line is, the longer the patient is responding. And we know for TVAC, for instance, that over 60% of patients responded for 12 months or longer. That's something we would never have seen before in melanoma. Now, this here is called a Kaplan-Meier curve. So the way this works is that you start with 100% of patients, and then you follow them over time, and you see then how many of these patients do not have the melanoma coming back. And the higher this curve is, of course, you like this to be at 100% of the time, but we don't always see that. But what we found in patients who had that initial complete response to TVAC, that all the tumor went away, when we follow them over time, and we look at 3 years, still over 70% of those patients, the melanoma has not come back. And you can see we're starting to see what's called a tail of a curve here, that if you make it out to that 3-year period, the likelihood of your tumor coming back is getting very, very small. So again, encouraging, and it's very exciting for us. And as Ken pointed out, the other thing that we find with these therapies is that they're really well tolerated. If you think about standard chemotherapy, you lose your hair, you vomit all night long, and it really can be very horrible. With many of these new therapies, patients tolerate them very well. I think that with these viruses that we inject, many times patients get a bit of shakes, chills, fevers. Those are the most common things, but very few patients have really severe side effects. So how well do these things work? Well, they work very well for patients that have melanoma that's sort of in the arm, in the leg, in the local vicinity. But patients that have melanomas that are in the lung and liver and other places, they work to some extent, but not as well as we'd like them to work. So I think in those cases, we really need to think about, well, what else can we do to try to add something to this so that we can have a better response in those lung and liver lesions. Now, also, many of you have heard this. The way we describe this is like driving your car. We want to rev up your immune system. We want to make the immune system go faster. So how do we do that? Well, it's like driving your car. To make your car go faster, you can press on the gas. Or, if you've got the handbrake on, take it off. So these viruses, really, they press on the gas of the immune system. They rev it up. And what we then do, we then combine them with other therapies to take the brake off the immune system. Now, there's one therapy that really, I think has changed dramatically the way we think about responses in melanoma. And that's a therapy called Nivolumab and Ipilimumab. And I know that there are a few of you here who have been on this therapy. So these are 2 checkpoint inhibitors. Both of these take the brake off the immune system. Now, you may know them as Opdivo and Yervoy. That's the brand names for them. Like a beloved child, these things have many names. Now, you can see here, this here is called a waterfall plot. So again, we never used to show these in melanoma. Now we show them all the time. And the way this works is that each line here that goes down is an individual patient. And 0 is that's where they start off with their tumor. If the tumor shrinks, we draw a line down here. If the tumor grows, we draw a line up. And you can see here with this combination that over half of the patients, the tumor decreases in size with this combination. But it can be really difficult to take. This combination can have a lot of side effects. And over half of the patients have these severe side effects from this, which really makes us more cautious that can we use this for everyone, or do we really select patients who may be able to go through and take this? So one thing that we're asking, well, how can we have the same response, that over half the patients respond, but we have less side effects? So we have some initial data. Again, this is very early data. But we have some initial data that in patients that have these lesions that we can inject, if we combine them then with one of these checkpoint inhibitors, the Yervoy, or here is the Keytruda, that we hope that we can get the same kind of response. And then we seem to have similar types of responses. Again, early data, we've never compared these head to head. The patients are different, we recognize that. But what's nice about it is that the side effects seems to be less. And the side effects really seems to be what we would see from Yervoy alone or Keytruda alone. So adding these viruses to these other agents does not really seem to increase their side effects. So again, early data, but very encouraging that we can try to do this. So where's the future then for all of these therapies? I think there is a future for them as monotherapy, as just a single agent, but also in combination therapies. But one thing that we are seeing also is that many times patients go on therapies and they don't respond. And we always ask the question, well, why is that? And we'd like to know that. And as Sherry said, we really like to find the best treatment for the patient right up front, the treatment that they're going to respond the best to, have the least amount of side effect, and have a long-lasting response. But we aren't there yet. Often what we're finding is patients who failed other therapies. So for instance, this is a patient here that has failed Yervoy and has failed Keytruda. When we take a biopsy of their tumor here, and the blue just means that this is kind of tumor cells, when we take the biopsy, we see that really seems to be only tumor cells in there. There are no immune cells. And really for these therapies to work, you have to have those immune cells need to be in there because you're activating the immune system. So the immune cells need to be in the tumor for it to work. What we do then, we take one of these oncolytic viruses, this is called TVAC or CVA21, and we inject this into the tumor. And after only 3 injections, we see a tremendous rushing of these immune cells now going into the tumor. So then we're asking the question, well, now when we have the immune cells in there, can we then give back, for instance, the Keytruda and then have a response? So that's where we're going next, to try to see if we can do that and really change the tumor microenvironment and change the immune system in the tumor to try to make these other therapies work better. Another thing that we're doing, we found out from the TVAC study that patients who had early disease, these are patients who did not yet have lung, liver, and brain metastases. We found that if they received TVAC, they lived longer. And we wondered, well, why was that? And we looked at the data and found that probably the reason that they lived longer is that it seemed that TVAC prevented them from developing lung, liver, and other metastases. So right now, we're actually doing a study in patients that have early disease that could have surgery for their early disease, either lymph nodes or in transits. But we're saying, well, we're going to treat them with TVAC for 3 months to try to activate the immune system, to try to sort of auto-vaccinate these patients before we do the surgery. And we're hoping that these therapies will then prevent the patients from developing tumors again. So these are some of the mechanisms we're doing. Now, you say, well, I don't want to have anything injected into me. I like intravenous stuff. I sit in a nice chair, they infuse things, I watch TV. I don't need to be stuck with needles. So the question is, do we need to give all of these intralesionally? And the answer is no. Some of these viruses we can actually give intravenously. And we're doing these studies right now to see if they work as well as giving it into the tumor. So the first question is, well, okay, so you're giving it intravenously. How do you know this actually gets to the tumor? It needs to get there to have an effect. So here, what we've done, we've given this virus intravenously. And again, the blue, remember, these are just cancer cells. Now, the red dots here shows the virus. And when we're giving it intravenously, we can see that the virus does go to where the tumor is and goes into these tumor cells. So again, encouraging that we may be able to, for some of these, give them intravenously. So these therapies are well tolerated. They have really low toxicity for patients. We see responses in both where we inject them and when we don't inject them. And also, they may be good in combination with other therapies. And I think that's really where melanoma therapy is moving overall, is to combination therapies. And we may be able to use them to change the immune system inside the tumor to make other therapies work better. Now, so why do we do this? This is all about patients. This is really why we're doing this. So this is one of my patients that you can see has a lot of, actually one of our patients, has a lot of melanoma in the neck over here. Now, she's 45 years old. She had melanoma that started in the neck, had surgery first, but the melanoma comes back. She's been on a lot of different therapies. She's had surgery, she's had the Yervoy. She actually had the BRAF mutation, so she went on a BRAF-MEK combination. But all of this, things started to grow throughout all of this. She then had the Keytruda, and again, things were still growing through the Keytruda. So we then did radiation, and she actually developed a brain metastasis. We did radiation both to the neck and the brain metastasis. So the brain was controlled, but the neck continued to grow. So she then went on one of our TVAC studies. And you can see, we know many times, as many of you have been through, when you've been through many of these therapies, it's sort of the possibility of the next therapy working tends to get less and less. But I think we're also finding out that in many times, maybe all of these therapies were just revving up her immune system. So finally, when we then put TVAC in, all the lesions slowly have gone away. So I think that this is another patient. He's got, again, melanoma in the neck here, a lot of lymph nodes. And we started with one of these oncolytic viruses that we injected, but the lymph nodes got bigger on that. And then we went and gave the patient Ipilimumab or Yervoy, but still with that, they continue to get bigger. We even gave radiation with the Yervoy, but they continue to get bigger. So we then gave them a second one of these oncolytic viruses and injected that into the lymph nodes, and there was a complete response. So of course, our question is, well, which of these therapies did the job? Because we know many times these immune therapies, it takes time for them to work. So was it the first injection? Was it the Yervoy with the radiation? Was it the second injection? I can tell you the patient does not care. But for us, we'd like to reproduce this for everyone so that we can see this for every patient and try to understand this. And this is why I think it's so important here at the Huntsman that, I know many of you, without saying names, have participated in the studies we do with Sherry. Really try to take these tumors, bring them back to the lab, try to understand how this works, and then from the lab, bring it back to the patients to try to find the best therapy for each and every one. So with that, thank you very much. And we're open to questions.